So hope you'll bear with me if I make some mistakes. I'll try to make this lecture technology. So what is the scope of this class is we're going to cover the salient features of tetralogy. We're going to talk echo differences between TOF and double outlet right ventricle. Then briefly we'll cover further variants such as tetralogy with absent pulmonary valve, tetralogy with pulmonary atresia, and also I'll try to give something about the post-TOF imaging. So is that okay? This is a question to the student. What are the main components of Fallot pathology? One of the common lesions that we see day in and day out. So what are the main components of TOF? RV outflow tract obstruction, right ventricular hypertrophy, and aortic override. So that is what makes the Fallot tetralogy. So what is like RVOTO? What is it like? Anterior and cephallar deviation of the outlet septum, which causes right ventricular outflow tract obstruction, and the result is right ventricular hypertrophy. And of course there is aortic root dilatation, so which gives the phenomena what we call as aortic override. To a certain extent it may be true, but most of it is because of the aortic root dilatation. Okay, coming on to the VSD, you've answered large perimembranous VSD. Now my question is, what are the types of VSD seen in tetralogy? When you see a tetralogy, what are the various types of VSD would you expect to see? The main types of VSDs are perimembranous, that's the commonest VSD that we see, it's about 74%. Then outlet VSDs. Outlet VSDs are the VSDs which have rim on both sides, so you have muscle which separates it from the tricuspid valve and which separates it from the pulmonary valve as well. So it's the outlet muscular VSD. Again, and a doubly committed VSD, which is called the oriental type of VSD, seen in 5%, is AV canal, not just inlet, AVSD, which may be in 2%, and yes, additional muscular VSD. Additional muscular VSD is additional, but main is 4 types of VSD that we see in Tetralogy of Fallot. Okay, now the components of the perimembranous VSD. So it is a large VSD which is located beneath the right and the non-thrust, and it extends up to the tricuspid valve. So there is a fibrous aortic tricuspid continuity. See, normally we talk of continuity in the aorta mitral continuity, but when we have a large perimembranous VSD, then the aorta is actually in fibrous continuity with the tricuspid annulus. And then how do we profile this VSD? It is best profiled in the short axis or the subcostal coronal section. A doubly committed VSD, what is different about this VSD? There is absence of the infundibular septum. So if you say tetralogy in true sense, then there is no infundibulum, so there is no infundibular obstruction. Entire obstruction here is by the hypoplastic pulmonary annulus and the pulmonary valve, and there is a continuity between pulmonary and the aortic valve. Some VSDs may be large enough to cover the entire outlet septum. They can cover up to pulmonic valve, but we have to differentiate because this is what is going to decide what the surgical approach is going to be, as transatrial, transpulmonary, etc. Outlet muscular VSD is a safer VSD, as we say. It has muscular edges on all sides, and there is aorta, pulmonary, and aorta tricuspid valve discontinuity. And AVSD is typically seen in Down children. Then additional muscular VSD. Well, there may be large, single, multiple, apical, anywhere. So that actually does not comprises of VSD for tetralogy. These are additional things. So what are the now components of pulmonary stenosis in tetralogy? What will you look for when you are doing the echo? Okay, so it could be infundibular. Yes, it is anterior cephalic deviation called septum, which is major cause, that is infundibular obstruction. But it could be infundibular, it could be at the level of valve, it could be in the supravalvular, and it could be in the periphery, in the peripheral conduit stenosis. And it can occur in various permutation and combination. Pulmonary arteries, they can be abnormal, especially in syndromes such as Atrial syndrome, and there can be hypoplasia of the pulmonary artery. There could be multiple areas of pulmonary artery stenosis. One could have unilateral pulmonary arteries. So all sorts of abnormalities are known, and we do look at the pulmonary artery size, and various textbooks have given various things how to measure the pulmonary artery adequacy. So we use what we call as Nakata index, Lagoon's ratio, and our center what we use is basically the Thirtian textbooks figures which are there, which gives us the pulmonary artery by weight. So we use that. And where do we actually measure the pulmonary arteries? They measure at the hilum just before the bifurcation. And peripheral PS is usually difficult to pick up, and if it is beyond the hilum, yes, proximal peripheral branch pulmonary artery stenosis, we can look at LPS stenosis or RPS stenosis, sometimes there will be bifurcation stenosis, that we can pick up. But beyond that, it is usually difficult to look into the pulmonary artery, so we require a CT scan or a cardiac catheterization, which adds an addition to echocardiography. So we've already talked about this pulmonary artery abnormality, and the views to be used for imaging pulmonary arteries have to be combination. We can use the subcostal short axis view, and we use the subcostal view. We also use the suprasternal view. So what pulmonary artery you would see best in the suprasternal view? Okay, yeah, the entire length of RPA can be seen on this. That's the right answer. Okay, aortic override, again as a component of Fallot tetralogy, can be between 10 to 95%, and some people use more than 50% override criteria to make it a double outlet right ventricle. Now, how many people think that aortomitral continuity is important to label it as double outlet ventricle? Should there be aortomitral discontinuity? So let's say there is a aortic override of more than 60% and there is no aortomitral discontinuity. So will it be a TOF or a DORV? Well, going by the 50% rule, it is a double outlet right ventricle because we have always defined valve by the 50% rule. Where some people look at the little muscle over there, but if you look at Anderson's classification, there is no attention to that. If there is any valve which is more than 50% into a given ventricle, it becomes committed to that ventricle. So we can debate on this later on when we come to that issue again. So I would call it a double outlet right ventricle, but yes, you can call it pathology, depending on what classification you follow. So what is the incidence of coronary artery abnormalities in pathology? And what type of coronary artery abnormalities should we look at? Yeah, the essential one is basically the coronary artery abnormalities which are crossing the RVOT. So it could be 5% cases have LAD from RCA, then 15% have large conal or accessory LAD, and single origin can be seen in 4% of patients. So it's roughly about 10% of patients who have abnormalities in the coronary artery pattern. Now, why do we want to look at these coronary artery abnormalities? Yeah. Okay, that's perfect. So yes, it is of surgical importance because any vessel which crosses anteriorly and you have inadequate coronary annulus, then your surgeon might require to put a transannular patch. In those cases, presence of anomalous coronary artery in that area may require something additional, sometimes double barrel, sometimes they are able to detect under or small gusset or whatever they get, but that's important and it's a good idea to inform the surgeon beforehand. So aortic arch can be abnormal in some, it's not really abnormal, it could be right-sided aortic arch in 25%, there could be aberrant subclavian artery, and right aortic arch has been found to be associated with higher ventricular diminution. Aortopulmonary collaterals common with pulmonary atresia. Small collaterals can be seen in very large number of pathologies. Sometimes may be difficult to image, especially if they are arising from the subclavian vessels. And if the patient is very few polycythemia, you may not get good flow in the collaterals, even if they are there from the aorta, despite adequate imaging. So deeply cyanotic patients may sometimes require another additional imaging modality in form of cardiac CT or cardiac catheterization. So what is your preferred modality in your institute? Just let me know, say CTs or CAT for imaging in pathology beyond echo. I know NH, they depend on CT. Okay, so CT everyone. CAT. Why CAT, Narayana? NH used to be CT place. RV outflow tract, because this is where we are going to look at the mandibular obstruction. We are going to look at subcostal, coronal and sagittal pain, parasternal short axis view, and parasternal long axis view through the RVOT. Then, of course, Doppler interrogation is important, color as well as the continuous and pulse wave Doppler, which will help us in defining the point of obstruction and degree of stimulus. So, show you some videos. Actually, I should have removed the heading, but let's see. So this is what view is this now? So this is a apical 4-chamber or maybe 5-chamber view as you would call it. looking at the aortic override and a large vesicular vessel defect. This is same picture from the subcostal. You can see the large malaligned VSD with aortic override. This is the interventricular septum and this large VSD. The important views, all VSDs should be interrogated in both the planes. This is through the long axis. You can see the color, right to left shunt, aortic override, aorta mitral continuity. Are you able to see the images as clearly? Just let me know, please. Okay, that's good then. So this is the subcostal coronal lifted to show the RV outflow tract. Guys can look at it. This is the tricuspid valve and this is the aorta here, huge dilated aorta, and you look at this is sort of continuity in between the tricuspid and the aortic valve. This is the indundibular septum and right ventricular outflow tract. If you look at this colored image below, here you can see the obstruction beginning much below the pulmonary valve. So it's clearly a infundibular obstruction along with the pulmonary stenosis. We are not able to look at the pulmonary valve as yet, but we can make out this is a perimembranous VSD because this is away from the pulmonary valve. This is a pulmonary valve here. This is away from the pulmonary valve. This is a perimembranous VSD from the subcostal section. The same thing can be looked at from the short axis view. So a perimembranous VSD here. The boundaries of perimembranous VSDs are formed by, can anyone please come on this? What are the boundaries of this perimembranous VSD? Tricuspid valve, the right and the non-first, and the outlet septum to various degrees. So this is a tricuspid valve, right in the non-first, can actually extend up to the non-first also. And from here it will be the membranous septum and can be going into the outlet septum. Now, this is the second type of VSD, second common VSD that we see in our day-to-day practice. So, this is what this is a doubly committed VSD. Can you make out here? This is hypoplastic pulmonary annulus here. Is the pointer visible? I am not sure if you can see this pointer. this is the VSD and this is the pulmonary annulus, and there is no separation between the pulmonary and the aortic valve. There is continuity is maintained. So this is a doubly committed VSD, and the pulmonary annulus is still not hypoplastic. So that's the main cause of obstruction in this kind of tetralogy. You can also see a red flow here coming into the pulmonary artery. That's tiny PDA probably. So same thing from the subcostal view. Can you appreciate this? This is different from the perimembranous VSD that we saw earlier. There is no infundibular septum. And there is a tiny PDA or a collateral coming inside there. So any questions so far on these two types of VSD? Now this is looking for muscular VSD. Now what would you do when you are looking for muscular VSD? What is the caution that you would want to observe while imaging? Yeah, perfect. So till what level do you bring it to? The advantage of bringing down the Nichols limit is the color lines the septum, and if there is any small crack, you will be able to identify. Lower than that, then everything gets illuminated, and you can be looking at tracks, and which will be called you'll be saying, okay, there is an additional VSD, but there will be nothing. So 40 to 50 is good enough to find out additional VSDs, and the next video is going to show you similar things. Okay, can you see this? This is the additional mid-muscular VSD in one of the patients. So there's an additional crack here, but this is what I wanted to focus. This is a small additional muscular VSD. While we are at it, we must also talk about the atrial communication. Some patients can have additional ASDs or a patient's foramen ovale. In these patients, it's a good idea to know it beforehand, because post-operatively, if there is a small atrial communication, the PO2 may not be good enough, and also these patients still remain sort of can have right to left shunting even in long term. So if there is a PFO, idea is to get it closed right at the surgical table. So just a continuous Doppler signal, and okay, I've already marked it for you guys actually. So this shows the two signals very clearly. Can you appreciate that? This is a sickle-shaped signal inside the what we call an ellipsoid signal. Is this visible here? The two signals can be separated out in some cases, and it's like infundibular as well as the valvular VS, the combination of the two. Okay. This is the short axis view, pulled slightly downward and anteriorly to show the pulmonary artery confluent, and we measure the pulmonary arteries in various views. So this is one of the views in which the pulmonary artery confluent is being measured. Here, suprasternal view showing the entire length of right pulmonary artery. So this is where the bifurcation will be, and you will be able to measure the pulmonary artery here. So can anyone name the structures visible in this view? What all do we identify? Because this is also the echo. So you should be able to identify the structures. Yeah. And what's below the RTA? Yeah, perfect. So, what I generally would do from this view when you are screening the right pulmonary artery, I would move the probe towards the left and look for the left pulmonary artery. Sometimes it opens up beautifully from the same view, and if it is not, you can actually move your probe towards just below the left clavicle, and from the left clavicle, just below the left clavicle, you are able to just look down this way. You look for the right pulmonary artery, and you will be able to see the left pulmonary artery. And can you appreciate this bifurcation stenosis here in this view? You can see the right pulmonary artery, the left pulmonary artery, and the bifurcation stenosis. So all these things can be picked up from suprasternal view just by moving the probe towards leftward. Okay, pulmonary annulus is being measured here. Again, subcostal view, and one has to measure the pulmonary annulus. We've already discussed that. We want to know what's the size. Does the patient need annular patch? Will the valve be adequate, inadequate? What is the morphology of the valve? Is it a trilateral valve? Is it a foaming valve? All these things can be assessed in this view. This video here in color and black and white shows the difference between the two pulmonary arteries, and there is origin stenosis of the left pulmonary artery. Imaging of RTA important because this is sometimes will decide the surgical path. You are able to appreciate the RTA arising. See, this is rotated sinuses. So our right coronary artery appears to arise, more towards the pulmonary artery because of the rotation of the sinuses. So as long as it forces towards right, it's going to be all right. It's not going to be in the surgical pathway. So you have to be clear that this coronary artery that you are seeing arising more anteriorly is the right coronary artery and is going and is forcing to the right side, and it's not the conal branch crossing anteriorly. Just as the sinuses are rotated, so left coronary artery tends to get pushed more posteriorly towards the posterior sinus. The left sinus comes to be more posterior. So just where the left coronary artery is. It's important to image both the coronary arteries. Can you see the right and the left in this? This is the right here and the left coronary artery. Both coronary arteries are being seen in this view. You may want to use color to confirm the coronary artery here. patient, we just said there's a large vessel crossing and posterior images are not adequate. So we had a cardiac catheterization or a CT scan turned out to be radiating from the right coronary artery. We've already talked about it, aortomitral continuity or discontinuity. Here again, what we follow in our institution is the 50% rule. If it is more than 50% override, we can label it as double outlet right ventricle. We do not look at the small tissue or a muscle present between the mitral and aorta. Yes, if there is a clear-cut aortomitral discontinuity, it's definitely DORV, but if it is more than 50% override, we in our institution follow the double outlet from the right ventricle. And tetralogy and DORV are not mutually exclusive. If it follows tetralogy, it could be double outlet right ventricle with CS. So you can use it, but use it carefully. Not that it is 200% override, 100% from the right ventricle, and you still call it tetralogy. So this video helps to sort out some issues. Good aortic override, aorta is definitely into the right ventricle, and there is this muscle here present between the aorta and the mitral valve. So what's the Hoffman variant of TOF? Anyone? Restrictive VSD occurs less than 1.5% of tetralogy. Cause for restriction could be accessory tricuspid valve tissue, sometimes could be hypertrophic septal band. These are the patients who are the thicker lot. That's the importance of this variant because RV gets squashed up from both sides. There is outward ramp obstruction and the VSD is restricted, so this is a suprasystemic RV. And these patients are the thicker lot, require early surgery. I'll just show you a video of this kind of tetralogy. I hope you guys will recognize this once you have seen it. Can you see this? Severely hypertrophic right ventricle and a restrictive ventricular septal defect. 6 septum and RV dysfunction. Same thing on the short axis view. Just look at this. Can you guys appreciate this small VSD here? It's kind of restricted. And look at the tight outflow tract. You guys seen this earlier? Yeah. So these patients are thicker ones, they will require early surgery. Okay, coming on to another variant, TOF pulmonary valve. Here, basically, what we find is a rudimentary and dysplastic pulmonary valve. There is element of Conduit Stenosis and pulmonary regurgitation. So what we have is a patient who has PS with PR, which leads to dilatation of right ventricle and huge pulmonary artery. And PDA is usually absent in this variant of pathology. So have a look at this video. This is rudimentary pulmonary valve here, big dilated pulmonary artery, and the color will show you the PS and PR. And this is the Doppler signal of the same thing, signal of PS and pulmonary regurgitation. Pulmonary artery dilatation can be unilateral, bilateral, in various permutation combinations, depending on where the death strikes. And these children can have variety of presentation. Some may be asymptomatic and may be coming to you electively, whereas those with significant pulmonary artery dilatation can have areas of bronchial compression. And these are the ones who are going to present very early in neonatal period, and these children require corrective surgery in the neonatal period itself. Some people do pulmonary artery placation, some would use a conduit to prevent further pulmonary artery incompetence, and some would do a LECOM. Our unit's policy is to do a LECOM or lift the pulmonary arteries off the bronchi and hang them behind the sternum in patients with significant bronchial compression. Okay, this variant, another common variant is pulmonary atresia. Here the RV output tract is completely atretic. There could be long segment atresia, it could be valvular atresia. Pulmonary arteries again can be in various permutation combinations. There could be presence of central pulmonary arteries which are good size, could be supplied by the PDA or the collaterals. There may be unilateral pulmonary artery, or there could be absence of both central pulmonary arteries, and there could be all collaterals. Again, these patients can have presentations which could be depending on the pulmonary blood flow. Those with very restrictive pulmonary blood flow will have severe cyanosis, right, and present to us in very early infancy with cyanosis and require the shunt. Those with collateral flow may be well balanced, have continuous almost bilaterally, may not be very much symptomatic in early childhood, but as they grow older, the collaterals tend to fibrose and thrombose and disappear. These children become symptomatic. And some patients can have large collaterals with unrestricted flow, so their symptoms are similar to the child with a large PDA or large truncus who go into early failure, and these children will require very early corrective surgery, especially the ones who are going into failure because of non-restricted pulmonary blood flow. So some videos on this variant. This is a short segment pulmonary atresia here. At a valvular atresia on surgery, it appeared to be bigger length and confluent good sized pulmonary artery fed by the PDA and a collateral. Small collaterals from the descending aorta, and this is large non-restricted collateral. One of the patients, huge collateral carrying large amounts of pulmonary blood flow. So this is modality where your echo probably needs to be supplemented by a cardiac catheterization, because one would want to have the pulmonary artery pressure or PA pressure through the collateral, one can enter the pulmonary artery. Here echo beyond confirming the confluence is not of much help beyond this. There is a limitation, so we always have to rely on CT scan or cardiac catheterization in order to get complete correction. Okay. So that completes the basic echo workup for patients with tetralogy. Then before I go on to the post-op issue, any questions from anyone? Okay. Should I move ahead? Follow-up and echo is the arrhythmia. No, but this is the echo session. We are only discussing the echo in imaging echocardiology. So yes, this is the long-term follow-up. So we have issues such as pulmonary artery growth. We have PR, RV dilatation, residual VSD, recurrent VSD, residual RVOT, and AR. Yes, arrhythmia, yes, but not for this session. We are only talking about the echo issues that we are going to deal with in our echo lab. And since we are all seeing a lot of pathologies in our day-to-day practice, so it is important that we need to know what do we look at when the patient of pathology who has been operated years back or recent has come for follow-up. So some patients who have not been given corrective surgery, who have just had BT shunt, we look for shunt patency. We look for pulmonary artery growth, and we look for the shunt distortion, PA distortion and the shunt sign. These are the two videos which will show you the shunt, the right and the left BT shunt, and in the upper video you can see the right pulmonary artery here, which has been pulled up by the shunt insertion, and there is some degree of pulmonary artery distortion. So shunt patency can be looked at from the suprasternal view, especially if the shunt has been done on the side which is opposite to the arch. Say for the left arch, the shunt is on the right side, suprasternal view is perfect. It gives you the total shunt length, and you can see the shunt origin, shunt insertion, whereas it's sometimes a little difficult to see the left pulmonary left VT shunt from the same view, so you have to rely on short axis cut to see the continuous flow. Is there a role of Doppler here to assess the quantity, or is it high flow or is it overflooding? Is there a role of any Doppler in this situation? If yes, then what is the cutoff value when you would say, okay, this shunt is overflooding? There will be some amount of increased pulmonary venous return to LA whenever you do a shunt in a patient. Velocities around 3 meters per second are probably, which have been reported by radiographer, are supposed to be adequate. Probably more than 4 or more will probably the shunt too small. And shunt, again, you see shunt is a long segment. It's not just one point stenosis. So the velocity should drop through the entire length. So probably 3 meters per second, what has been reported in many textbooks. And yes, a low velocity shunt, yes, often indicates some degree of overflooding and elevated coronary artery pressure. Yes, there is some role, but isn't really good. But I think it's good to have the total picture, whether the patient has features of coronary pleura, is the lungs look wet on X-ray. Then yes, what the LA return like, and then of course the saturation and stuff. Again, when we are looking at TOF Fallot, so we are looking at residual VSDs, RVOTs. I already told that. Going down and to the next slide quickly. Probably 3 meters per second, as they say, is okay. Anything less than 3 is supposed to be high flow. Personally, I have not had any 100% experience on that. Let's say, okay, 2 meters per second is high flow. But yes, if the patient has the flooding and you're getting low flows, okay, yes, you can put 2 and 2 together and say, okay, fine, this is the low flow and this patient may be overflooding. But then there can be other causes. Shunt, basically shunt low velocity in some degree of elevated CF pressure. This could be another cause, okay, and chest infection or anything, and yeah, that could cause elevated CO2 levels, inadequate ventilation. So again, shunt velocity will go down. So when we look at histology nowadays, instead of doing when they're doing total correction, instead of removing and pulling out the entire muscle, the surgeons nowadays prefer to leave some degree of right ventricular outflow tract obstruction, some degree of muscle they say is restricted, because it gives some degree of restriction to the RV outflow tract, and in the long term these patients are supposed to fare better. So with gradients up to 25 to 30 or 40, so they are acceptable in the early post-operative period, and the way these gradients usually tend to come down during follow-up. Rarely we have seen the muscle obstruction increasing and patients requiring routine surgery, but most often gradients of 25, 30 up to 40 in the immediate post-operative are acceptable. So this kind of mild RVOT is alright if you're getting this kind of signal in the patient who's going home or has come for follow-up for first visit, second visit, probably going to be okay. This is a video showing a large, significant residual VSD in a patient who's been operated. You can see dilated LALV, and there is a big shunt and the patch dehiscence in the outlet septum. Then, besides the main VSD patch dehiscence, it is not uncommon to find additional VSDs that have been missed, especially the VSDs which are in the posterior part of the inlet. Because sometimes when we are looking at from the apical view and we say, okay, it's large VSD, and the posterior inlet septum is usually what we call as blind spot for the echocardiographers. So subcostal view will help in differentiating, in probably identifying additional VSD, especially in the posterior inlet septum. So if there is any doubt, one could go in for a PE during perioperative or post-op period, or immediate after the surgery before they come off bypass completely. So additional muscular VSDs could be missed, and they can cause problems in the perioperative period. Small VSDs are okay, but large significant residual shunts require immediate correction. This is what happens when they put a transannular patch. You see there is no valve, and you have a free PR, there is no murmur in this patient, but this patient is going to fare worse than the patient whose echo we saw earlier, where there is some degree of RVOT obstruction, because your free PR is going to cause RVOT dilatation, and sometimes we have seen that this outer edge of the patch starts impinging on the LTA origin, causing LTA origin. This is what we look at. Look at this hugely dilated right ventricular outflow tract in the patient. That's the original MPA. So this is the result of free PR. We are lucky that nowadays most surgeons are not doing short annular passes. They are trying to minimize the use of short annular pass as much as possible and leaving some degree of RVOT in the patient. Aortic incompetence usually tends to be progressive. It can be there right in the beginning, like one of these patients who had significant aortic incompetence. So a valve had to be repaired at the time of surgery itself. But even in the post-op period, some patients can have progressive AR and require aortic valve replacement. Aortic incompetence is linked besides pulmonary incompetence, which has to be looked at every time the patient comes for follow-up. This is not two methods for looking at RV function, but we tend to follow this in our institution. Similar to what we do as for left ventricle, we try and do it for as RV fractional area change. So this gives probably not 100%, but this tends to give you, you can follow a patient serially. So this was the area change, and now this is decreasing. The area, RV area increases, the volume going up, and for serial follow-up, you can't have MRs at every time a patient visits. So something like this, which is a rough tool, can be pretty handy. We also use TAPSE for RV function assessment, which is the M-mode, takes a tricuspid valve annulus, the anterior wall of tricuspid RV annulus there, and whatever measurement you get, that's the maximum exposure, you multiply that by 3, which will give you roughly the ventricular function. Here the distance is 16 millimeter. The 16 times 3 is 48, which is fairly good function for right ventricle. It is again not a true assessment, but a value above 45 is supposedly all right for all your patients. So this is again, you can assess, a serial assessment of a patient can be done by these two techniques. This will help in future follow-up and planning future intervention on the patient. Nowadays, there was one study which has come up again, the angle index between the lateral and the medial pulmonary annulus, and they say as the right ventricle starts dilating, the lateral annulus of the tricuspid valve goes increasing, and that angle can help us decide the further intervention. Some patients are lucky, they have what we call as a restrictive RV physiology. A restrictive RV physiology is marked by presence of anti-grade flow in the MPA during each cardiac cycle, and a flow velocity of around 50.5 is considered to be appropriate to call it a restrictive RV physiology. Now, any reason why this restrictive RV physiology is supposed to be better? It is a double-edged sword. Why is it better for long term? Restrictive RV physiology, I would say, is better because it restricts the PR, because RV is a little restrictive, so it reduces the pulmonary regurgitation, impact of pulmonary incompetence. In the initial post-op period, a restrictive RV physiology usually is associated with what we call as a low cardiac output state. So patients with restrictive RV physiology in the immediate post-op period can go to low cardiac output state, where you may require to support them, but in long-term restrictive RV physiology has been found to be better for these patients, and their RV does not dilate as much, even with pre-PR. So it is sort of protective mechanism. And you can also use the tissue Doppler. Velocity excursion of more than 8 is again consistent with restrictive physiology. So these patients are going to be better, they are better in the long-term follow-up, those who have restrictive RV physiology. Then quick word about post-op conduit. A lot of children with pulmonary atresia or in our institute, patients with PSVR, that is septic pulmonary valve syndrome, end up with conduit, and we have to follow these patients annually. Again, we have to look at RV outflow tract obstruction, which would be secondary to patients outgoing the conduit, or simply because of calcification and degeneration of the conduit, or thinking of the conduit. Then valvular degeneration, that is, there could be pulmonary valve incompetence of the conduit valve, and conduit PA junction stenosis. So all these have to be assessed in every patient and every time. This is a video of a patient who is now 5 years post conduit. You look at the RV dilated, hypertrophic, and reduced contractility. So these patients, if not followed properly, can present with RV dysfunction, dilatation, and ER. The same patient, you have severe conduit obstruction, conduit velocities of more than 80 in this patient, and RV dysfunction. These patients will require a conduit replacement. In this patient, there was obstruction only in the initial part, ended up with conduit replacement and conduit change. But there could be conduit pulmonary artery stenosis, distal stenosis, which may be amenable to balloon dilatation, but for conduit stenosis itself, surgery is the best solution. I guess that brings us to the end of the talk.